This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Chalk City 91.1 FM, and on Facebook at TTT Live Online. We now go to Al Alexander, Senior Corporate Communications Officer at the Ministry of Health.
Good morning and welcome to another Ministry of Health's virtual media conference where we provide you with clear, accurate and up-to-date information on the national COVID-19 response. Our panelists today are Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health, Roshan Siram Singh, Geographic Information Systems Manager at the Ministry of Health, and Mr. Trevor Khan, COVID-19 survivor. And I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and your moderator for this morning's media conference. I now invite Dr. Hines to present the latest clinical, vaccination, and epidemiological updates. Dr. Hines.
Thank you, Mr. Alexander. Good morning to my colleagues, Mr. Siram Singh and Mr. Khan. Good morning to members of the media and members of the viewing and listening public. If I could have the first slide, please, we'll go through the clinical update. Now, as at July 6th, next one, please. Thanks. As of July 6th, which is yesterday at 4 p.m., 238,502 tests for COVID-19 would have been conducted at both public and private facilities. Of those, 33,805 would have come back as positive. So you've had 33,805 confirmations, and of those, 903 deaths. And we extend our condolences to the members of those bereaved families. So far, there have been 26,524 total recovered patients, and patients designated as currently active stand at 6,378, those being broken up as follows. There are 5,666 persons in home self-isolation. There are 339 individuals at hospital, 123 at step-down facilities. Those in the hospitals being broken down as follows. Those in the Couva Hospital and Multi-Training Facility standing at 98, Cora 39, Augustus Long 48, St. Anne 7, Arima General 52, New Point Fortin Hospital 39, St. James 34, Scarborough 21, and Scarborough Signal Hill 1. Now, the vaccination status as we currently stand is 220,748 individuals having had their first shot, and 123,497 individuals having had both doses of a WHO recognized and approved vaccine. There are currently 233 people in state quarantine facilities at this time. And as of yesterday, there were 250 new positive cases identified in the time period that would span between July 2nd and July 5th. If we can move into the EPI update, we see that the curve that we have become accustomed to seeing is heading in what we consider to be the right direction. Let's have that curve back up, please. And that is that the bars on the right-hand side, the most current ones, are progressively shorter, not as tall as the ones before, indicating that there are fewer cases. So the new color, if we get the graph back up, that new fuchsia color is the color representing the days in the month of July so far. And we see that those so far have been shorter or fewer cases than the ones in the month of June, and those in turn shorter than the ones in the month of May. So that rolling average or that dotted line is trending downwards, and that is an encouraging sign. It means that what we're doing is working with respect to slowing the spread of cases, and we need to continue to do it, especially in the face of the increased movement that we expect with some of the releases in restrictions that we have recently been advised of. Next slide. If we look at this same data now aggregated on a weekly basis, we get a look at the totals by week and, more importantly, the percentage change in those totals from one week to the next. And what we've been seeing, looking at the blue bars, is that we see that progressively shorter and shorter bar moving from left to right, indicating progressively fewer cases accumulating at the end of each successive week. The last percentage change we had from one week to the next was about 20%, and that was between the completed week 26 and the week before that, which was week 25. So we are continuing to see that downward movement. And the salmon section at the back, that orange or salmon background with the red border, represents the percentage positivity, which has been coming down, although it is wavering a bit. It's a little higher this week than it was last week. And we again are just watching that variation because we need to see whether that is what we call a blip or whether it is an increase in trend. So we're going to continue to monitor that as we continue to test throughout this week. But we are expecting that we will see lower numbers of cases again this week as compared to last. Next slide, please. If we look at that same information again, compiled on a monthly basis, we see that the month of May had the highest number of cases. June had fewer, and we're hoping that July continues that trend, that downward trend quickly, so that we have even fewer as July progresses. Again, a lot of this is going to depend on how we adhere to the public health regulations, even as we move more, and also how we uptake our vaccines, which is an important part of or an important layer in that protective strategy. Next slide. Looking at the demographics, we see that the age-sex distribution has remained largely the same. We note that there are just about 50% men and 50% women among the positives at this point in time. We also note, although it would take some memory, that the over 60 age group has slowly but steadily been increasing over the past, let's say the past month. We've seen that they've been accounting for a steadily increasing proportion of the total number of cases. And when we look at that broken down even further, those in the 70 and above age group have also increased to some extent. And this reflects itself, unfortunately, in our next slide, where among the fatalities, we have been seeing that there's been an increase in that over 80 age group, and the overall balance of male to female has swung from being about 75% in the early years, before March or so, to now just about 60% male and 40% female. In this case, 58.9 to 41.1. Noting that as we get more of the older population affected, the probability of having an adverse outcome is higher, and you're seeing that reflected in these figures. So again, we want to encourage those who know that they have family in the elder care homes who may not yet have given permission for them to be vaccinated to go ahead and do that, because that's one of the very important strategies for protecting the older population from those adverse outcomes. So with that, I'm going to turn you over to Mr. Alexander.
Thank you very much, Dr. Hines. And it's good to hear that we're heading in the right direction, step by step. We now go to Mr. Siram Singh for the latest GIS update.
Thank you very much. Dr. Hines, Mr. Khan, Mr. Alexander, members of the media, members of your listening and viewing audience, good morning. Today we begin by taking a look at our first map, which represents the cases recorded during epidemiological weeks 21 and 22, which cover the period when combined 23rd of May to the 5th of June. What we see is what we've seen in the past, and that is a preference for those areas which are highly populated, so the population centers, as well as areas along major road networks across the country. We take a look at the chart briefly, because we'll take a deeper look shortly. We take a look at the chart and we see that general trend downwards in Epi Week 22 when compared to 21, which in this case, Epi Week 22 is covered and colored in the goldish yellowish color points and bars, whereas Epi Week 21 is covered in the purple points and bars. We move quickly to the next map, which shows us again the points representing cases recorded during epidemiological weeks 22 and 23. So there's the overlap with Epi Week 22 in this case, with Epi Week 22 covering the period the 5th of May to the 5th of June, and epidemiological week 23 covering the period the 6th of June to the 12th of June. We see for the most part, most of the counties continue that downward trend, with the exception of County Caroni, Mayaro, and St. Patrick, which we saw slight increases during that particular week. However, generally the trend during that week moved downwards when we look at the data nationally. And again, the cases showed a preference for those areas with higher population and along major road networks where population settlement is taking place. As we switch and move to our next slide, we take a look at the cases distributed by county and divided by epidemiological weeks, covering the period Epi Week 21 to 23, which was represented in the previous maps. We see again, generally in most of the counties, that downward trend from epidemiological week 21 to 23, with the exception of County Caroni, River Mayaro, and St. Patrick. We see that downward trend with that significant drop from epidemiological week 21 compared to 22, and of course a subsequent drop in 23 compared to 22. I will point out that epidemiological week 23 is not complete at this point in time. We are just about 87 to 90% complete with that particular week. However, we expect the trend to remain the same when we are completed with that exercise. As we move to our next map, we look at the same information which we presented earlier. We look at the points aggregated at the community level. And in this first map, we are looking at the period epidemiological weeks 21 and 22, covering the period 23rd of May to the 5th of June. And if you recall from our last presentation of such a map, which represented at that point in time epidemiological week 20 and 21, in this case now we are looking at 21 and 22, you will see a similar pattern in terms of the communities which are affected. So we see the majority of communities across the country remain affected. It remained affected at that point in time, with several communities in the East-West Corridor, as well as Sangre Grande, and some in Central, that is in County Caroni, recording very high numbers of cases, in several cases being over 50 per community. If we take a look at epidemiological week 22 and 23 in our next slide, what we see in this map is, again, while a majority of communities continue to record cases, we are seeing less communities recording that over 50 mark. So less communities are recording in that particular range, which is a good sign. Of course, it represents a downward trend. And similar areas continue to be affected. That is the East-West Corridor, the St. George Central and St. George East. Again, we see the Sangre Grande and those areas in County Caroni. We take a slightly different look at the data now as we switch to our next slide. And what we look at in this particular map is space-time trend analysis. So what we did in this particular case, we looked at the data which would have been mapped for epidemiological weeks 20 to 23, which covers the period the 16th of May to the 12th of June. So generally about a month thereabout. What the analysis does is it allows us to identify upward and downward trends. So we are seeing areas which are showing the increases, the continuous increases, and areas which are showing the continuous decreases over those respective epidemiological weeks. I will point out that on this particular map, the hexagons which we see in red represent those areas which are showing increases, and those in blue represent the areas which are showing decreases. Those which are colored white identify those areas which show no significant trend. So we cannot identify if there is a significant increase or decrease in those areas. However, the focus at this point will really be on those in which we were able to identify a trend, so the increases or decreases. You will note generally that there are a few areas which showed increases or continuous increases over this period, and it was scattered across the country. We'll take a closer look at some of the counties shortly. But generally, most of the areas are showing that downward trend, thankfully, at this point in time. So we have known that we are seeing the decreases for some time. We have seen it week by week as the numbers come in. And what we are seeing now is where the decreases are taking place. You will recall in probably the last map I showed, there are several areas which continue to record a high number of cases. You would note as well that in this map, some of those areas are showing a downward trend. This is because the hexagons are 1 kilometer hexagons. The communities are of a different size, of course. So what we are seeing is that there may be pockets within these communities in which we are seeing decreases as we go along. So we take a closer look at what is taking place at a more granulated level. And we see what is taking place in this particular instance in County Caroni. Before we go into that, however, I want to point out that despite these areas showing decreases over time, we need to continue to practice the measures. It is important for us to continue to practice the 3 Ws of washing our hands, wearing our masks, and watching our distance. We should not at any point in time become complacent and misinterpret these maps to suggest that all is well. The fact is that the numbers are decreasing, yes, and we are thankful for that. However, we want to continue to do what we've been doing and what has been working to decrease the numbers, the 3 Ws being key among those. Here we take a look at County Caroni, and we see that there are several areas which have been showing decreases, with a few areas scattered across the county showing increases. I want to point out as well that these are 1 kilometer hexagons, so it's quite possible that spread within the home is also driving the increases in these few areas. That is something that is quite possible. We have seen in the past spread taking place within the home, and of course, looking at a smaller geographic area, there's a higher chance of such spread influencing these outcomes. We switch now to our next map, which looks at County St. George Central. And again, we're seeing several areas in which there are no identifiable trends in terms of increases or decreases. However, we are seeing several areas showing that general decrease, and that will be more in the central part of the lower central part of County St. George Central, with just one area showing signs of an upward trend. As we switch to our next map, we take a look now at County St. George East, which generally is showing us that downward trend or no identifiable trends at this point in time in several areas. However, there is one area in which we are seeing that general upward trend. Again, it is possible that these upward trends are as a result of spread within the home and those who will be in contact in that sort of environment. And we now switch to County Victoria as we take a look at what is taking place there. Again, the majority of areas we can't, at this point in time, identify a specific trend in terms of upward or downward movement in a number of cases. However, there are several areas in which we can identify it nonetheless. So we are seeing downward trends scattered throughout the county in several areas, with 3 areas showing increasing trends at this point in time. As we move to the last slide now, I remind everyone that if you wish to access credible COVID-19 information, please feel free to visit the Ministry of Health's website at health.gov.tt/COVID-19, and to access the GIS dashboard, we click on the drop-down, the COVID-19 drop-down that is, and select Trinidad and Tobago COVID-19 dashboard. Thank you very much, and I'll hand over to Mr. Alexander.
Thank you very much, Roshan. Ladies and gentlemen, the effect of COVID-19 on the majority of the population has been difficult, even more so for those who would have contracted the virus and their families. Mr. Trevor Khan is a COVID-19 survivor, and we are pleased to have him on set this morning to share his experience and advice with us. Mr. Khan.
Good morning. Thanks very much, Al. Members of the panel, ladies and gentlemen, good morning. I am grateful for this opportunity to be with you this morning to share my experiences. In late October last year, October 27 to be exact, I was diagnosed with the COVID-19 virus. Fortunately, I had been home for some time before this, taking the necessary 3W and all other precautions. Nonetheless, I one day suddenly developed classic symptoms that came on in quick succession: the dry cough, elevated body temperature, fatigue, loss of appetite, nausea, all relatively mild at the start. The sustained public education campaign was enough for me to know to go get tested. The result came back positive, and perhaps like every patient who has received a positive test, my world momentarily stopped to a halt. I was directed to the public healthcare system for further assessment. I alerted my family immediately, with concern especially for my 2 kids who would have been exposed to me over the incubation period. I went straight to the COVID-19 screening facility at Mount Hope General Hospital. There, I was administered with a barrage of tests, including a nasopharyngeal PCR test, various blood tests, a blood oxygen level test, chest X-ray, and continuous monitoring of vitals as well as having received IV fluids due to dehydration. The hard-working doctors at Mount Hope checked on me continuously while I was there, and I was in awe of their professionalism, and I'm extremely thankful to them to this day for their excellent care. I was sent home many hours later to recover at home, and I was fortunate to recover at home over the next few weeks, but not without suffering through the host of initial symptoms I experienced. I was isolated from my family and survived many anxiety-filled nights alone through the prayers and positive thoughts of my friends and loved ones. By mid-November, my life seemed to return to normal. I felt much better and my energy had returned. But then, just as suddenly, things appeared to change when on December 31st, as I sat participating virtually in All Year's Night Holy Mass, a wave of dizziness hit me to the point that I felt I would surely pass out. This was the beginning of the sting in the tail of the dreadful virus for me. The weeks and months that followed saw me experiencing a range of additional symptoms, including lightheadedness and vertigo, chest pains, palpitations, and chronic fatigue. I had no energy to do all the things I did previously with ease, and my COVID symptoms seemed to be lasting much longer than expected, and my life had changed. Research on the phenomenon of long COVID, also known as long-haul COVID, was just beginning to emerge, and finally I found an online support group where thousands of people from across the world, many like me, previously in good health, sometimes only having a mild case of COVID-19, were now dealing with numerous health issues. Thankfully, months later, after many specialist consultations, tests, and supplements, I am seeing a greater return to some semblance of normalcy. Yet, I still lived with the dread of being reinfected. But then came the great news that vaccines were coming. Having immersed myself in research over the preceding months, from reliable sources of course, I did not hesitate to get myself vaccinated, as the chance of reinfection is well known and well documented. I was also aware that the vaccine is no silver bullet against reinfection, but that it does lower the risk of serious illness, hospitalization, and death. There were even stories that long haulers, as they are now called, people with long-lasting symptoms, would see improvements in their residual symptoms after being vaccinated. The key messages I came across doing my research about vaccination were more than enough to convince me that getting vaccinated was the best way to stand up to this disease. These were: 1, vaccines have long helped in the life-saving battle against viral and other illnesses, and 2, despite the record speed at which they have been developed, COVID-19 vaccines have still been subject to the same checks, balances, and scientific and regulatory rigor as any other vaccine, and indeed many of them use tried and tested methods that have been in existence for many years. On June 18th, I received my second jab. I am now fully vaccinated. I am thankful to the nurses for their professionalism and efficiency during that process, and I continue to take all precautions and try to convince others who are in doubt to do their research, especially against the myths and the urban legends surrounding the vaccine. I remind them that social media platforms are not the best sources of scholarly and reliable medical information. I also remind them that we all had been vaccinated as children, and now as parents, we place our trust in vaccines as we take our newborns for their various shots. Ladies and gentlemen, I urge you to do your research. Visit reliable sources of information such as the Ministry of Health website, the World Health Organization website, and other reputable medical and news platforms. Do your part and be vaccinated. Protect yourself, your loved ones, your co-workers, and all of those you come into contact with. In closing, in the words of the World Health Organization Director General, Dr. Tedros Adhanom Ghebreyesus, This is a time for facts and not fear. This is a time for rationality and not rumors. This is a time for solidarity, not stigma. Ladies and gentlemen, I thank you for your attention. Please be safe and God bless.
And thank you, Mr. Khan, for your advice and experience. Thanks for sharing that with us. As we transition to the question and answer segment, we want to remind our media representatives to state their name, media house, and identify which panelists they wish to pose their questions to. We want to start with CNC3.
Morning, everyone. Rashad Khan, Guardian Media Limited. My two questions this morning are for Dr. Hines. Okay, so I would have noticed, Dr. Hines, that when you were presenting the epidemiological update, you made reference to a rise in COVID-19 cases among those over 60 over the past month. Now, if we throw our memory back, we remember that these were the category of people who were lining up for hours to get a COVID-19 vaccine outside these health centers and stuff. So has there been any sort of link between these cases and these events, people contracting the virus while during that whole rush to get vaccines? And has it shown up during your contact tracing exercises? And now my second question is, we have heard that a 15-year-old girl would have died from COVID-19 within the past 2 weeks. Now, I know that the youngest person on record that we were told publicly was around October last year, and it was an 18-year-old girl. So is this person the youngest person that would have died from the disease, or is there anyone younger? Thank you.
Okay, thanks for the two questions. Now, the first question that you ask is an interesting one, and the short answer is actually no. What we're seeing is sort of a steady increase over a given time frame that actually preceded that incident where there were people lining up for a time period that was actually reasonably short. We looked at and we actually looked for an increase or a bump or a spike at the sort of 2-week mark after that particular event, and actually did not see one. And the possibility is that because it was in limited numbers of places and the duration was actually cut short by dispersing the crowds, etc., the event itself may not have had the time to sort of generate the spike that we may have been looking for or expecting if that had gone on for longer or had involved more people. So we did look out for it. We looked at the sort of that event was on the 9th, I believe, of June, and because it was what you would call a point event, like when people go out in large numbers to one particular thing, then that point event would be expected to have a sort of a point outcome sometime later. What I'm describing with the over 60 age group was really a gradual increase in the proportions over the last maybe month to 6 weeks. And a lot of it was actually driven by seeing cases and clusters in some of the elder care facilities, which is why we took the opportunity after making that point to make the point of the vaccinations and the importance of vaccinating that particular age group and that particular vulnerable group within those facilities. And again, we want to make sure that people hear that call and provide the necessary permission or consent to have their elders, where they can't consent for themselves, have those elders vaccinated. Now, the second question, the range of death, the age range for those who have passed on from COVID-19 at present ranges from 15 to about 98 or 99. That's the full age range, and it's actually demonstrated, or you see it within the age-sex distribution pyramid that we put up for the deaths, where the lowest age group is actually that 15 to 19 group. And then we have people in the 85 and above. And again, we saw where that 85 and above section actually began to occupy a larger and larger percentage, again, driven by that sort of infiltration into those more vulnerable facilities. So I think that answers both of your questions.
Thank you very much, Dr. Hines. We now move to I-95.5 for your two questions.
Yes, good morning, everyone. Whitfield Turner, I-95.5. Dr. Hines, I want to continue with you in the absence of the CMO taken on from where I left off on Monday, as it pertains to persons entering the country when the borders reopen. Now, persons who would have received their 2 doses but didn't get to the 14-day post-vaccination point will not be treated as fully vaccinated. So I was wondering, such persons, they would get to that 14-day point most likely while in quarantine. What happens then? Is it that they will be allowed to go home, or will they have to continue and complete their 14-day quarantine? And what about considering 7-day state supervised quarantine and then 7-day home quarantine for fully vaccinated persons? And my second question, persons who are vaccinated with vaccines that are not WHO approved, would they be allowed into the country? And if so, how will they be treated?
Okay, now, first thing I'd like to do in responding to that question is to let the public know that the full guidelines for the repatriation process, the altered or the modified repatriation process, those guidelines are now available from the Ministry of Health website. That's www.health.gov.tt. So you can go onto the website and download those full guidelines and refer to them at your leisure. With respect to the first question, if someone has booked a flight and they're traveling before they've reached that 14-day mark, then they're basically just treated as not yet fully immunized. So it's a sort of a binary category. You've either gotten your 2 doses of vaccine and you're 14 days beyond and are then considered fully immunized and treated as such, or you haven't met some one of those criteria and they're treated as not fully immunized. So there isn't any distinction within the quarantine process for that. You'd go through the process for the not fully immunized. So, too, individuals who have received a vaccine that is not on the list of WHO, EUA, and EUL approved vaccines at this point in time. So we're really doing a very binary process, either fully vaccinated with recognized vaccine or not. And once we fall into the not, then not vaccinated nationals will come in through that repatriation process that involves the 14-day state-supervised quarantine, and non-nationals who don't meet vaccination criteria need not apply at this point in time. So I believe that answers the questions.
Thank you very much, Dr. Hines. We move to Newsday. Ms. Lindo, we are ready for your questions.
Hi, good morning. My questions are for Dr. Hines. The first one is the Lambda variant a cause for concern in TNT, especially given that borders are to reopen soon? And will Trinidad and Tobago give consideration to mixing vaccines as is being done in other countries, especially if our supply is not steady? Thank you.
Okay, thank you. Now, the Lambda variant is called a variant of interest as opposed to a variant of concern. And at this point in time, any variant is of concern, as we are aware that movement of people will, of course, increase the risk of introduction of additional virus and possible variants. Now, that being said, we do want to re-emphasize that the processes that we put in place, including requesting a negative PCR 72 hours before travel and requesting that people be vaccinated prior to coming in, those 2 things will, of course, help to reduce that risk. But we continue to be aware of and wary of the potential for introduction of variants, and we continue to do the sequencing to the extent that we have the capacity to do so, to detect as we move forward. With respect to the second, again, we need to bear in mind that the only mixed schedule that has been approved so far is that single one by the WHO, and we will not at this point in time be entertaining other mixtures until such time as there is additional evidence to support the efficacy of some other mix. So at this point, where we only have one of the two vaccines that is in that approved mixed schedule available to us, we will not be mixing any of the local vaccines that we have here as we move forward with our vaccination rollout. I believe that answers what you didn't ask. So we won't be mixing what we have. The only mixture that will be approved are the ones that have been approved by WHO, and we don't have that combination in Trinidad.
Thank you very much, Dr. Hines. We move across to Tobago Channel 5. Ms. Jackson, good morning.
Good morning, Candice Jackson from Tobago Channel 5 News. My questions are in regards to the increase of cases among some of the elderly in our nation. Do you think that it might be connected to variants that are around in the population? And are we increasing our testing for variants as well?
Okay, thank you for the two questions. The first, now we know that we have had the introduction of that Gamma, or what we called P1, or previously Brazilian variant, into the population, and that when a more transmissible variant integrates itself into a population, it basically establishes an equilibrium. It becomes some proportion of the circulating virus. So in as much as we've had that introduction and we know that it is part of the circulating group of viruses, it is quite likely that the people who have been affected in the older age group could have one or other of the variants, either what we had before, which was actually the R1, or this newer variant that was introduced, which is the P1. So the answer to that is it's quite possible because both things are circulating at this point in time. And the answer to the second question is yes, we are increasing or looking at getting the additional resource and capacity to increase that sequencing so that we can get a better and more representative idea of what's in circulation in the population in general.
Thank you for your questions, Ms. Lindo. We now move to IETV for your two questions. Good morning.
Hi, good morning. Bina Hayes, IETV News. My two questions would go to Dr. Hines. Dr. Hines, do you have any updates, in case you missed it, as to the number of COVID-related deaths that would have occurred outside of the hospital settings? And my second question, cases are on the decline, which is good news, but if deaths continue, you would have said in the past that the increased deaths was as a result of the increased number of cases. Can we therefore expect to see a decrease in deaths in the near future? Thank you.
Okay, thank you. So the last update that we had put the number of deaths outside the health system in general, meaning deaths at home, at around 6.9%. As we fill in some of the gaps in some of the data that we have, we'll again provide an update. So we don't necessarily get all of the information on each case filled all the way in when it arrives on the desks of the epi division. So sometimes you have to go back and verify place of death, etc. And that constitutes the next update. So we're doing that right now. So far, it doesn't look like there's any great change in that proportion. So we're gonna estimate it around that same 7% at this point in time. And we do hope that as the new cases that come into the system go down and the active cases that exist in the system recover, that we're going to have fewer deaths going forward. Bearing in mind, of course, that we still had the last active case update was 6,000 and something. Let me just get that for you. Total active cases as of yesterday, 6,378. So 6,378 people are still being followed, they're still being monitored, and they still are yet to be designated in the outcome category, preferably and hopefully and most likely recovered. But out of those, there will be some proportion that will contribute to the fatality figures because that's just how the virus actually operates and how it operates across the world. So there should be, we expect to see, decreasing numbers of deaths going forward. And we can rest assured that the health system, the healthcare workers, take every single patient very seriously, work very hard to ensure a positive outcome for every single patient, and they try their best to ensure that everyone has a good outcome and gets to go home in a recovered state.
Thank you for your questions, Ms. Mahis. We now go to AZP News. Good morning.
Good morning. Priya Bihari, AZPnews.com. My question is for Dr. Hines. Dr. Hines, you mentioned at the beginning about long-stay homes. ACP News have had some people tell us that there is a high level of vaccine hesitancy among the staff of these homes, and the relatives of some residents are concerned that there is a likelihood that if their relatives contract the COVID-19, it is unlikely that they'll survive. So I don't know if the ministry is aware of the situation and if there's anything that can be done. That's my first question. And secondly, I wanted to ask Mr. Khan. Mr. Khan, some persons who have had COVID-19 say that they have difficulty in breathing still, after months. Do you think that you are back to 100%? And what are some of the major effects you are still having, or are you back to normal? Thank you very much.
Okay, thanks for the question, Mr. Bihari. Now, the only thing we can do with respect to vaccine hesitancy anyway is to encourage individuals to look at the research, to listen to credible sources, and to trust in the system that has provided a range of safe and effective vaccines for global use. Now, we aren't specifically aware of a hesitancy problem among staff in these facilities, but again, we want to reach out to all healthcare staff and to all persons in the population to have faith in the vaccines, to utilize the vaccines that are available, and in so doing, you protect not only yourself, but those who are in your care and in your presence, whether it's at your workplace or at your home. So here again is an opportunity to plug the acceptance of and the uptake of the vaccines where they are made available. I'll turn you over to Mr. Khan for the next question.
Thanks very much, Prior, for the question. I could only speak to my personal experience. And as I mentioned in my presentation, I would have tested positive on October 27th last year. I did have a lot of residual symptoms post that, which included, as I mentioned, fatigue, various aches and pains, something called brain fog, which is, a bit of disorientation, a bit of forgetfulness, cardiac-related issues, pulmonary-related issues, neurological-related issues. Thankfully, I would say about 95% back to normal. I do have some moments of fatigue now and then. I do get some shortness of breath now and then. But by and large, I would say I'm 97% back to normal after 8 months post-diagnosis.
We are certainly happy to hear that, Mr. Khan. We move to Radio Tambourine for your two questions. Good morning.
Yes, good morning. Clayton Clark, Radio Tambourine. My two questions, but this is a follow-up to the issue of vaccine hesitancy. How has the response been by relatives of the elderly to give permission to the elderly to be vaccinated, particularly those at care and elderly home? And secondly, has any consideration been given, or has the state seek to order the Cuban vaccines? And if not, will consideration be given? And will these vaccines fall under the COVAX facility?
Okay, thanks for the two questions. Now, both of these were addressed a few times in the past at previous health conferences and at the Prime Minister's health conference. The Minister himself indicated that there was an ongoing call to remind and to encourage the members of families of those persons in the elder care facilities to give permission or to give concurrence or consent where the elders themselves were unable to do so because of some form of cognitive decline. And that is improving slowly but surely. We want to continue to encourage those relatives to help to protect their elders by allowing them to be vaccinated. And we are seeing slow but steady improvement in that. We want to encourage that to continue. We've also addressed before the issue or the question of the Cuban vaccine or any vaccine that's currently not under EUL. Once a vaccine becomes emergency use licensed and authorized, then it becomes eligible for consideration within our health system. Before that, there is no consideration. Once it becomes licensed, then we can have that discussion. At this point in time, the vaccines that have been licensed are the ones that we've been looking at. And until such time, the issue of whether it's going to enter into COVAX or not is not one that we can respond to.
Thank you very much, Dr. Hines. We now move to TV6 for your two questions.
Hi, good morning to everybody on the panel. Alicia Boucher from TV6. My first question is for Dr. Hines. Dr. Hines, a little over a month ago, I believe you stated that you had noticed a trend, a shift in the trend as it relates to deaths linked to COVID-19, where deaths linked to diabetes in particular were decreasing, and you had linked that to the possibility of vaccination. So can we have an update whether you are still seeing the same thing? And my second question for Mr. Khan, I have both a request and a question. You said that based on your research, you had seen where once a person is vaccinated, it can assist in, relieving some of the symptoms as it relates to long COVID. So I wanted to find out, since you have been vaccinated, have you noticed an increase in your health and those residual symptoms that you were having? And the request is for the public's benefit, can you share with us that support group that you would have been linked to in case other people want to link themselves to it? Thank you.
Okay, thank you for the question. Now, there hasn't been any significant or major change with respect to the contribution of diabetes and hypertension among the comorbidities. But what we did notice is that because people who are diabetic and hypertensive have been among the target groups, that those who have been vaccinated will now be in a lower risk category for having adverse outcomes. So while it hasn't changed the proportion significantly, diabetes and hypertension are still the majority of the comorbidities that we see in the fatalities. We do note that those who have been vaccinated are now at a lower risk, and we want to continue to encourage those who have not yet been vaccinated but have the opportunity to do so to take that opportunity up. I'm going to turn you over to Mr. Khan for the second question.
Thanks a lot for that question. I received my second dose on June 18th, which was more than 2 weeks ago, so I'm now fully vaccinated. I have to say that I was on a positive recovery trajectory prior to that. So I won't say for sure that, the vaccine would have brought any improvements. I had already been on, as I said, a track of improvement prior to that. With respect to the support group, the online support group, excellent support resource. It's called Survivor Corps, C-O-R-P-S, Survivor Corps. And they are on the internet. There's a website as well as a Facebook group as well. Excellent resource for people who have had long COVID or long haul COVID issues. So I encourage you, if you have those symptoms, to please check it out.
Thank you very much, Mr. Khan and Dr. Hines. We now move to 103 FM for your two questions.
Hi, good morning to everyone. Rai Rikomas from 103.1 FM. My first question, actually both questions are to Dr. Hines. The first is regarding the criteria for hospitalization. You mentioned that active cases are above 6,300 and there are about 339 persons in hospital. What's the criteria for hospitalization, and does it change based on the number of active cases? My second question has to do with the over 60 age group. You mentioned the long stay homes, the elder care homes, being one of the areas of concern with that age group. But where else within that age group do you see levels of concern in terms of spread and contracting the disease based on your contact tracing so far?
Okay, thank you. Two excellent questions. The first is the clinical criteria. Now, the clinical criteria for admission do not change with the number of active cases. So what we do have is a clinical assessment of each individual, and if they are having any derangements of function, any issues that suggest that they need secondary or tertiary level care, that's an individual assessment that would be done for each patient, and then they would be admitted accordingly. So if they have their normal comorbidities out of control plus shortness of breath or low oxygen levels or any of those things. So it's not a specific list that we can say, okay, checklist these 3 things and now you're going in. It is an assessment of each individual to see their level of physiological stability. If they are unstable in any way and require hospitalization, then that is done. And the filling of the hospitals that we saw previously was really due to the large proportion, a large number of individuals who were in the population as active cases, and the consequent proportion of those that would need hospitalization, which was around 14-15% at some point in time. And that, again, corresponds to international levels. That's the same sort of behavior we saw with the populations across the globe with regard to the need for more advanced care. Now, the second question is another excellent one. The people over 60 that aren't in elder care or other facilities that we were seeing getting ill were generally those in households with other COVID-positive individuals in many cases. Sometimes they don't know where they actually would have picked up the illness because nobody in the household was ill. But we did see quite a few cases of in-house spread. And again, we want to emphasize the importance of the isolation behaviors and precautions even within the household. When you are a COVID-positive patient that doesn't require hospitalization and has been asked to home isolate, the importance of isolating yourself from your family members is really very, very key to not getting other people in your household ill. So the wearing of the mask, the keeping to one part of the house, the not interacting in shared spaces, not sharing utensils, cleaning down surfaces after you've used them, all of that helps you as the infected, isolated individual in a home not to transmit your infection to other individuals, because household spread was yet another area, another scenario in which people over 60 were becoming infected.
Thanks a lot, Dr. Hines, and of course for those 2 questions. We do have time for a few more questions, and so we will facilitate 1 follow-up question per media house. We go back to Guardian Media Limited for your follow-up question.
Hi, good morning again. So, Dr. Hines, when the GIS data was being presented, County Carney has been identified once again as being one of those standout counties, I would say. You know, those that kind of seem to be not going with the trends. I know Dr. Siram Singh, or Mr. Siram Singh, sorry, would have made some mention of what could be driving the this continued high infections within the county. But what else are we seeing propelling County Carney to be one of the standout counties?
Okay, I'm not sure whether the question should really go to me or to Mr. Siram Singh, but I will begin the answer, and Mr. Siram Singh can chime in if needed. Now, it's really important to note that the spread of this virus within any community is driven by adherence to the various recommendations that we've been making for risk reduction. And it may not be specific or community sensitive, or it may not be related to a given community or county, but the spread of virus anywhere is related to the extent to which people are aware of the status, people are aware of the need to self-isolate when they are ill, the testing when you go, or the isolation when you feel ill. All of these things are the drivers for people to reduce their risk of transmitting to others. And while we can't say geographically that there is a difference in those behaviors that we have collected data on in any county, we do want to point out that those are the things that are going to help to drive transmission, and fixing those things are the approaches that are going to help reduce transmission. So wherever we know that we may not be feeling exceptionally well, this is an opportunity for us not to spread whatever is making us feel ill by self-isolating or by going for a test and then being followed up by the healthcare system. If we've actually been diagnosed, we want to again encourage people to follow the isolation rules. If we've been family members or contact of those who have been diagnosed and we should be in quarantine, we want to again encourage individuals not to breach quarantine because they feel well, because you could be an asymptomatic positive, and we do want to encourage the reduction of mobility and movement of those who should be in quarantine but aren't, because that again is going to be a driver. So this isn't county or community specific information or advice, but it is really the general advice that we want to give everybody in terms of little things that we can do to reduce the risk of transmission. And of course, we want to encourage the entire population, as vaccines become available, to avail yourself of these vaccines, so that again we add an additional layer of risk reduction and protection to the entire population. Mr. Alexander?
I'm not sure if Mr. Siram Singh had anything to add to that. Yes?
All right, thanks very much. So I'll point out two things. One, the period represented on the maps would have been from a few weeks back. So it may not give an idea of what exists currently as at today. So we are looking at a few weeks back. That is the first thing. The second thing is, as Dr. Hines mentioned, the same reasons or the same influencing factors which exist in County Carney are the same reasons or influencing factors which will exist in the other counties as well. Spread within the home, of course, continues to stand out. And that is the one thing that I can say from a mapping and contact tracing point of view that we have been able to identify. And again, these are issues which exist and continue to take place in other counties as well. What it does for us is highlight the need for us to continue to try as best as possible to avoid any unnecessary interaction outside of the home, so that we avoid any situation whereby someone can bring it into the home. And of course, within the home, continue to practice the measures, as Dr. Hines would have mentioned earlier, with the isolation, of course, and sanitizing services and whatnot. Thanks very much.
Thank you very much, Roshan. We quickly go to Newsday for your follow-up question.
Hi, good day. My question is regarding the over 65 people. People are still asked, well, when would the Ministry of Health be rolling out the appointment system for people who aren't, in a clinic or in an elderly home or somewhere where the Ministry of Health knows that they are? How do these people access the vaccine rollout?
Okay, thank you for the question. At this point, what we're looking at, or what's driving the vaccine rollout, is the availability of various batches of vaccine. As we get batches in, and the volumes give us a guide as to who can be targeted or who can best be targeted, we'd better be able to give guidance on the best approach. We know that we are looking at additional IT solutions to improve the experience with the acquisition of vaccine appointments, and as that gets updated, that information again will be shared. So keep looking at the Ministry of Health's website. Stay tuned to that for which approach would be most beneficial as more vaccines become available. That vaccine rollout appointment system is one of the things being actively worked on, and the targeting of groups that may not be in health centers or belonging to the clinics, etc. That targeting also continues. So these are additional methods of ensuring that the widest possible coverage is attained.
Thank you very much, Dr. Hines. And ladies and gentlemen, we have come to the end of today's media conference. We once again thank the media for their engaging questions, and you, our viewing and listening public, for sharing your time with us. Please note the COVID-19 vaccination rollout continues in all RHAs for persons 65 years and older, and for those persons scheduled to take their second jab. We also want to encourage the caregivers and the patients in our elderly homes to get vaccinated, and I know Dr. Hines and Mr. Siram Singh would have focused on that. And of course, as the COVID-19 restrictions have been eased, we want to remind you to remain vigilant. Adhere to the COVID-19 health protocols to protect yourself and others. That is, wash your hands, watch your distance, and wear your mask. Have a good day, everyone. Stay safe, and goodbye for now.
Three, 4, 5, 6, 7, 8, 9, 10. Centrally located, good to go.